This guide gives doctors advice on a special radiation treatment for early stage breast cancer. The treatment called partial breast irradiation (PBI), and it only targets the part of the breast with cancer, not the whole breast. The advice is mainly based on lot of research and evidence. It makes sure that the treatment works for patients with early stage invasive breast cancer and ductal carcinoma in situ. ASTRO formed a team to look into PBI treatment. DCIS means there are abnormal cells in the milk duct. WBI is whole breast irradiation. IBR is the return of the cancer in the same breast where it was originally diagnosed. The study found that PBI resulted in similar rates of IBR as compared to WBI. The team wanted to answer 4 main questions. The first one is, when is it better to use PBI instead of WBI? Secondly, what methods should be used in PBI to get the same result as WBI? 3. How much radiation should be given and how often? And finally, what parts of the breast should be targeted and what are the details of how the treatment should be given for different PBI techniques. To understand the effectiveness of PBI, they used different techniques. There are 6 types of modalities that were mentioned in the research. The first one is multi-catheter interstitial brachytherapy or MIB. This involves placing multiple small tubes into the breast tissue. Radioactive seeds are then inserted into these tubes to deliver radiation directly to the tumor site. Secondly, single entry catheter brachytherapy. This is also known as intracavitary brachytherapy. It involves inserting a single device into the cavity where the tumor was removed to deliver radiation. The third one is 3-dimensional conformal radiation therapy or 3D CRT. This uses special computers to precisely map the location of your tumor. Radiation beams are then shaped to match the shape of the tumor and delivered from several directions. The next one is intensity modulated radiation therapy, IMRT. This is an advanced type of radiation therapy that uses computer-generated images to plan and then deliver more precise radiation doses to the tumor while minimizing the dose to adjacent healthy tissues. Number 5 is proton RT. This is a type of radiation therapy that uses protons rather than X-rays to treat cancer. Protons can be controlled to release their energy within the tumor site rather than passing completely through the patient, reducing the radiation dose to healthy tissues. And finally, intraoperative radiation therapy, IORT. What is IORT? This is a treatment that delivers a single large dose of radiation directly to the tumor site during the surgery. It can be done using electrons or protons. Next, dose fractionation. Hypofractionation is a treatment regimen that delivers higher doses of radiation in fewer visits. Moderate hypofractionation is defined as less than 20 centigrade but up to 499 centigrade per fraction. And ultra hypofractionation is defined as less than 500 centigrade per fraction. The guideline addresses 4 key questions in the PICO format, and PICO format is mainly population, intervention, comparator, and outcome. Let's break down the key questions in PICO format table. For population, it's adult patients with early stage invasive breast cancer or DCIS. Intervention is treatment or procedure. In this case, here it's PBI and the techniques that are mentioned. Next is comparator. It means PBI is compared to WBI plus or minus boost. The plus or minus boost means that the treatment may or may not be followed by an additional dose of radiation to the area where the tumor was removed. And the last one is outcomes. These are the results that are measured to see if the intervention has worked or not. In this case, it's IBR, and IBR means the return of the cancer in the same breast. The guideline is intended for adult women with early stage invasive breast cancer or DCIS who have undergone breast conserving surgery. It does not cover patients of male sex as this was an exclusion factor for the RCTs. It also does not cover other important questions such as more advanced cancer or patient of male sex or the role of PBI followed by WBI and oncoplastic surgery, recurrent of cancer. Key question 1. Key question 1 was when it is better to use PBI instead of WBI. Multiple randomized control trials. Multiple RCTs have shown that PBI is as effective as WBI. However, the use of PBI depends on both patient and the tumor characteristics. PBI is generally a good option for patients with certain features, such as being in the postmenopausal age range or having ER-positive status. Having a small tumor size and no lymph nodes involvement are also favorable. But there is uncertainty about using PBI in patients with less favorable features. These include being under 50 years of age or having ductal carcinoma in situ, then having invasive lobular carcinoma or a larger tumor size, grade 3, and then ER negative status, HER2 positive status, being positive for LVI, and having positive lymph nodes are also less suitable. There has been hesitation to use PBI in patients under 50 years of age. It because due to concerns about increased IBR risks. The available data do not suggest a difference in recurrence risks when patients are treated with WBI versus PBI. Patients with grade 3 invasive disease, a more aggressive form of cancer, were less represented in the studies comparing PBI to WBI. However, the data suggests that PBI can be considered for patients with grade 3 invasive tumor. Tumor subtype is also an important factor for treatment decision. PBI is mainly supported for patients with ER positive and HER2 negative, but caution is recommended for patients with more aggressive disease such as HER2 positive and ER negative. Patients with LVI where cancer cells have spread to the blood vessels or lymph systems were underrepresented in the studies. There is a potential higher risk of recurrence, so caution is needed to give PBI to patients with LVI. Patients with lobular histology were also less represented in the studies comparing PBI to WBI. This type of cancer is more likely to be multifocal, meaning it can occur in multiple areas of the breast. Therefore, the appropriateness of the PBI in this setting is poorly defined. Patients with positive axillary lymph nodes, meaning the cancer has spread to the lymph nodes in the armpit, were also underrepresented in the studies. So, PBI is not recommended for patients with nodal disease. Surgical margin positivity, where cancer cells are found at the edge of the tissue that is removed during surgery, was an exclusion criterion for most of the studies. PBI is not recommended for patients with positive surgical margins. Patients with a germline BRCA1 or BRCA2 mutation, a genetic mutation that increases the risk of breast and ovarian cancer, were specifically excluded from most PBI studies. Therefore, PBI is not recommended for this patient population. Patients with DCIS were included in 4 RCTs. These studies found minimal difference in up to 10-year IBR rate between those treated with PBI versus those treated with WBI. Small and low to intermediate grade DCIS can be treated with PBI, but high grade and larger than 2 cm volume DCIS might not be suitable for PBI. Key question 2. Appropriate PBI techniques with respect to IBR outcomes. Large trials have not been done to compare the rates of cancer returning in the same breast for different PBI techniques, but several large trials have compared individual PBI techniques with WBI. These trials show that the IBR outcomes achieved with different forms of PBI. MBI was the first PBI technique to be compared with WBI in a trial, and 2 such trials have been conducted. Both showed no significant difference in IBR outcomes for MBI versus WBI. Most patients in trials comparing PBI to WBI were treated with a technique called 3D CRT, and one trial showed a small difference in 10-year IBR rate between PBI and WBI. But another trial showed that a similar 8-year IBR rate for PBI and WBI. Only 2 trials directly compared IMRT to 3D CRT PBI, and both trials focused on toxicities. And one trial showed a similar IBR rate for IMRT PBI and WBI. Pencil beam scanning is a new way to do proton beam PBI, but there is not enough data to say if it is good or not. Proton beam PBI might be better for hard to reach areas like near the breastbone. IORT is a type of radiation that can be done during surgery, and this could make treatment easier for more people. There are 2 types of IORT. One is electron IORT and the other one is photon IORT. But there are some challenges. For example, doctors might not have all the information they need about the cancer when they do the treatment. And it's hard to make sure the radiation is going to the right place. In one study, IOERT didn't work as well as WBI plus boost. WBI plus boost is when you get a big dose of radiation after the main treatment. The study followed 1,305 patients for 15 years. The IBR rate for IOERT was 12.6%, but the IBR rate for WBI plus boost was only 2.4%. Sadly, both groups lived about the same amount of time. The study also looked at a smaller group of 141 women, and these women had a very low risk of cancer coming back. They had small, slow-growing tumors. The IBR rate for IOERT was 8.1%, but the IBR rate for Germo plus boost was 3.1%. Photon IORT is a type of radiation treatment, and it's done during surgery, but it's hard to understand how well it works. This is because some patients also got WBI after IORT. In a study called Target A, patients got either WBI or photon IORT. After 5 years, the IBR rate for photon IORT was 3.3% and 1.3% for people who got WBI. But about 15% of these people who got photon IORT also got WBI, so it's so hard to know if photon IORT works as well as WBI. Also, over 20% of patients who got photon IORT during surgery needed WBI later. This was based on things like how big the tumor was and where it was. So it's quite hard to know who will do well with the just photon IORT. Because of these issues, photon IORT alone is not recommended. The Florence, HIPAB and import law studies suggest safe PBI doses. The Florence and HIPAB studies found that PBI using 3000 centigrade in 5 sessions safe. They compared it to WBI and found that similar local recurrence rates. The import law study tested 4005 centigrade in 15 sessions over 3 weeks for PBI. It showed similar control and less late normal tissue toxicity. The Danish cancer group also found PBI non-inferior to WBI. All of these studies kept dose and fractionation constant. Despite these findings, concern over toxicity with twice daily regimens and patient convenience were considered. New studies are looking at different ways to give PBI. Some are using new techniques or giving treatment on different days. Early results are promising, but we need more time to see how well this works. One study called Fast Forward compared a 1-week WBI treatment to a 3-week WBI treatment. They found that the 1-week treatment worked as well as the 3-week treatment. But the 1-week treatment caused more harm to healthy tissues. This shows that changing the dose and timing of treatment can have big effects. Some groups now say that a certain dose of PBI, like 2600 centigrade in 5 treatments, is a good option. This is actually based on studies that showed PBI can cause less harm to healthy tissues, but more research is needed. When giving PBIs, it's really important to target the right areas. This can depend on things like how big the tumor was and where it was. So, doctors might need to adjust treatment for each patient's fraction. EBRT radiation is aimed at a specific area that is called target volume. The size of this area can change. It depends on how much cancer was removed during surgery. The treatment can be given in different ways. One way is called HDR. Another way is called pulse dose rate brachytherapy. These methods were tested in two trials. The trials were called GEC ASTRO and B39 by R0413. In the GEC ASTRO trial, they used both HDR and pulse dose rate brachytherapy. They gave the treatment twice a day, and some patients got 7 treatments, while others got 8 or 10 treatments. In the B39 by R0413 trial, they also used HDR brachytherapy and they gave the treatment twice a day. All patients got 10 treatments. The trials found that both treatments worked very well, but there were fewer side effects with PBI. The trials also looked at how to plan the treatment. They had different goals. If the goals were different, they used the stricter one. This is called the ideal goal, and the other goal is called acceptable. The trials also looked at the dose of radiation, and they found that lower dose can be used with modern equipment, and this reduces side effects. The trials looked at the size of the cancer-free area around the tumor. This is called the surgical margin. The size of this area can affect the treatment. If the size is not known, they use a standard size, and the standard size is called alternative size. Key question 4. The question was appropriate PBI techniques with respect to toxicity and cosmesis. PBI uses less radiation than WBI. They should mean fewer side effects, but it's not that simple. The results depend on many things. These include the type of PBI and the dose of radiation. The tests done so far have used different methods, and they have also measured different things. So it's hard to make general statement. Some tests used IMRT, and this has fewer side effects. It also makes skin look better, but these tests were done a while ago. The way we treat cancer has changed since then, so it's hard to say if these results still apply. There are also other ways to give PBI. One way is to give it once a day. This can be done on different days, or it can be done on the same day. This has fewer side effects. It also makes the skin look better. But again, it's hard to say if these results still apply. PBI given twice a day does not seem to have a good results. This is based on two RCTs comparing it to WBI. The rapid studies showed less short-term side effect with PBI, but it had more long-term side effect. These were mostly due to patients with hardening and spider veins in the PBI group. Patients and nurses also reported worse look with PBI. The B39 by R0413 trial had similar results, but it included all PBI methods as one group. So it's also hard to tell if there were differences between the methods. The quality of life and looks results from the trial have not been published yet. The IRMA trial found low but increased rate of late soft tissue and bone side effects with PBI. It also found worse look at 3 and 5 years. This is similar to the rapid study. The GEC ASTRO trial found that MID had less short-term skin side effect, but it had more blood clots, infections and injuries compared to WBI. The Budapest studies did not report on short-term side effects. There were no big differences in long-term side effects in either of the MIB trials. But MIB had similar or better looks compared to WBI. There is limited data on single-entry catheter PBI compared to WBI. In the import low trial, both PBI and WBI used the same dose fractions. But PBI had less change in breast appearance and hardening. The Danish Breast Cancer Cooperative Group RCT also found the lower rates of breast hardening with PBI. Early use of photons for PBI had worse short and long-term skin side effects compared to photons, but other studies found reasonable results. The proton collaborative group and the Mayo Clinic found minimal side effect with pencil beam techniques, and more data from phase 2 trials will help decide on the use of proton PBI. Conclusions and future direction. Treatment for early stage invasive breast cancer and DCIS is changing. There is a move to use less local therapy. This includes surgery and radiation. The Society of Surgical Oncology suggests not doing sentinel lymph node biopsy in some patients. These are patients over 70 years old with certain types of breast cancer. The RCTs of PBI require patients to have axillary lymph node sampling. As more patients do not have this, future studies will need to look at the impact of this. They will need to see if more axillary evaluation or therapy is needed. There is encouraging data and ongoing efforts to find more patients who can safely not have adjuvant radiation therapy. Patient-centered, informed, shared decision making will be more important. This will be used in discussions about the radiotherapeutic management of early stage invasive breast cancer and DCIS. Patients with known BRCA mutations were mostly not included in the PBI trials. This is because they have a higher risk of developing new cancers in other parts of the breast. As we learn more about genetic mutations, it is important to understand their impact on the use of PBI. Breast implants can get hard and look bad if they get radiation, and this is called capsule contracture. It might need another surgery. Radiation causes this by making the tissue around the implant hard. If we can give radiation to less breast tissue, it might lower the risks, and we need more studies to know the best way to do this. It is not clear yet that if IORT is a good option. It's faster and has less side effects but might not control the cancer as well. We need more data on this. Preoperative PBI is when you get radiation before surgery. Clinical trials are ongoing to assess its toxicity and tumor control with ultra-hypofractionation. The study didn't have enough data on different types of patients and tumors. This make it quite hard to compare WBI and PBI, and most of the studies and real-world data can help improve this. Genomic panels which look at the person's genes might help decide who would get PBI. The studies didn't have much data on the race and ethnicity of the patient, and future studies should include more diverse patients. PBI shouldn't be denied to a patient based on their race or ethnicity. It's hard to offer PBI to patients who have had oncoplastic procedure. More studies are needed to find the best way to do this. Comparing the side effects of PBI and WBI is also difficult due to different dose plans used in the studies. So more research is still needed as treatments continue to evolve.